Welcome to the sixth Pharmacy 15, where I'll review CT contrast media. CT contrast media is a crucial diagnostic imaging tool that works through iodine atoms, which have the remarkable ability to absorb X-rays about 350 times more effectively than soft tissue. This property makes it invaluable for visualizing blood vessels, organs, and tissues during imaging procedures while maintaining normal physiological function. We'll explore four key aspects of contrast media, including one, properties, to understand the chemical structure, ionic characteristics, and key factors like iodine concentration, osmolality, and viscosity. Two, pharmacokinetics, to review how contrast media moves through and is eliminated from the body. Three, adverse reactions, including safety considerations, potential complications, and prevention strategies. And finally, nuclear medicine applications for the role of contrast media in nuclear medicine, particularly in PET-CT procedures. We'll start with the properties. Contrast media's chemical structure determines the effectiveness and safety. First, we'll look at contrast from the monomer and dimer perspective. Monomers contain a single 2,4,6 triiodinated benzene ring. Benzene ring is a highly stable core structure of 6 carbon atoms in a hexagon shape to which the iodine atoms bond. The benzene ring structure itself helps to reduce contrast toxicity. Monomers can be ionic or non-ionic, which we'll discuss in a minute. Dimers, on the other hand, have two connected benzene rings. Dimers generally have lower osmolality. Osmolality is nothing more than the concentration of dissolved particles of the contrast agent. Dimers allow high iodine content while maintaining lower osmolality. We can also classify contrast based on ionic properties. Ionic agents dissolve or dissociate into charged particles. Non-ionic agents remain intact. Whether a contrast agent is ionic or non-ionic is an important distinction for adverse reactions. When we talk about osmolality, which again is the concentration of dissolved particles, there are three categories. First, there's HOCM, or high osmolar contrast media, which has an osmolality of 1,400 to 2,100 milliosmoles per kilogram. LOCM is low osmolar contrast media, which has 600 to 800 milliosmoles per kilogram. And then there's IOCM, which is isoosmolar contrast material, which has an osmolality of about 290 milliosmoles per kilogram, which is very similar to plasma. Understanding the key properties of contrast material is crucial to safe administration. First, we'll talk about iodine concentration. Contrast media iodine concentration is typically about 200 to 400 milligrams of iodine per ml, depending on the agent that's used. Higher iodine concentration equals better opacification, but increases risks. There's a delicate balance between diagnostic quality and safety. Next, we need to talk more about osmolality and what it affects. Osmolality affects fluid shifts within the body. High osmolality causes water to move from the interstitial spaces into the body's vascular compartment, causing a circulatory response. Higher osmolality increases adverse risks. Modern contrast agents trend towards lower osmolality. Another property of contrast material is viscosity. Viscosity is the thickness or stickiness of a fluid. Viscosity affects the flow rate and injection pressure of contrast material. Lower viscosity material flows more easily through catheters and blood vessels, enabling better visualization during imaging. Lower viscosity also exerts less shear stress on vessel walls, reducing the risk of complication. Viscosity decreases with increasing temperature, which improves flow. Viscosity is important to consider when contrast is used with power injectors. The fourth property relates to patient characteristics. such as weight, age, and renal function, injection protocol required, and the specific organ or pathology being evaluated. Next, I'll discuss pharmacokinetics. I love saying that word. The pharmacokinetics, or movement of contrast material in the body, follows a two-compartment model referring to how contrast is distributed and eliminated in the body. Contrast material reaches peak plasma concentration in 2 minutes and then rapidly diffuses into the interstitial spaces between the cells and tissues. Interestingly, contrast does not cross the blood-brain barrier or enter neural tissues or the testes due to tight cell junctions that prevent contrast movement into these areas. Also, contrast is not metabolized and is eliminated unchanged in the urine. It is rapidly and almost exclusively eliminated by the kidneys through glomerular filtration in people with normal renal function. However, the elimination half-life can increase to 40 hours or longer in people with renal dysfunction. Interestingly, contrast has a biphasic half-life. In the first phase, 12% of the contrast is eliminated within 10 minutes, range of 2 to 30 minutes. The second phase of excretion occurs in about an hour and a half, and 50% is eliminated with a range of 1 to 2 hours. Nearly 100% of contrast material will be excreted in patients with normal renal function within 24 hours. Moving on to adverse reactions. Use of new non-ionic agents has significantly reduced contrast reaction rates. Adverse reactions can be classified into three main categories. First, anaphylactoid reactions mimic anaphylaxis but are not true allergic reactions. Chemotoxic reactions are organ-specific due to the chemical properties of contrast media. Such reactions include nephrotoxicity or thyrotoxicosis. Vasovagal reactions are fainting caused by a reflex nervous system response. Delayed reactions can occur 1 hour to 1 week post-injection. The common manifestations of contrast reactions include hives, which occur in about 53% of all reactions, and nausea in 18% of reactions. Reactions vary in severity from mild to life-threatening. The incidence of mild reactions is about 3% for non-iodic contrast and 15% for ionic contrast. The incidence of severe reactions is 0.04% for non-ionic contrast and 0.2% for ionic. Risk factors for contrast reactions include previous contrast reactions, asthma, allergies, heart disease, dehydration, and renal disease. One reaction of significant concern, particularly for at-risk patients, is contrast-induced nephropathy. Contrast-induced nephropathy, or CIN, is a type of acute kidney injury. CIN occurs when the contrast material damages the kidney tubules, leading to inflammation and reduced blood flow to the kidneys. This can result in a decrease in urine output and an increase in serum creatinine levels, indicating kidney damage. The risk of developing CIN is higher in individuals with pre-existing kidney disease, diabetes, heart failure, older age, low blood pressure, and a large volume of contrast media administered. CIN is diagnosed based on a rise in serum creatinine levels after contrast administration. Treatment focuses on supporting kidney function and preventing further damage through intravenous fluids, medications to improve kidney blood flow, and dialysis if necessary. Fortunately, most cases resolve within a few days to weeks. However, in severe cases, CIN can lead to permanent kidney damage and death. To prevent CIN, patients should be screened for risk factors before contrast administration. The lowest dose of contrast should always be used. Patients should be well hydrated before and after the procedure, and consideration of alternative imaging techniques that do not require contrast media when possible. IV contrast material can react with many medications, including anticoagulants, metformin, beta and calcium channel blockers, and other nephrotoxic medications. Specifically, metformin increases the risk of lactic acidosis in patients with pre-existing kidney issues, leading to impaired kidney function and a buildup of metformin in the body due to its primary renal excretion pathway. To mitigate the risk of metformin interaction, metformin should be withheld for 24 to 48 hours before IV contrast procedures. Nephrotoxic medications include nonsteroidal anti-inflammatory drugs, or NSAIDs, loop diuretics, angiotensin-converting enzyme inhibitors, and angiotensin receptor blockers. These medications should be withheld based on the half-life, and the patient should be well hydrated. Prevention is our first line of defense. This includes thorough patient screening, appropriate prophylactic medications when indicated, proper hydration protocols, proper injection technique, and monitoring during contrast administration. Prophylactic medications usually include diphenhydramine, also called Benadryl, and steroids such as methylprednisolone, which is solumedrol, and hydrocortisone or solucortep. Monitoring should include checking renal function before and after contrast administration, tracking patients' symptoms for the first 20 minutes post-contrast injection, maintaining IV access for at least 30 minutes post-procedure in high-risk patients, and documenting any adverse reactions and patient response. Being prepared for emergencies is crucial. Most severe reactions usually occur within the first 20 minutes after IV contrast administration, and while rare, fatal reactions do occur in about 1 in 170,000 patients. Emergency medications that should be on hand include epinephrine for severe reactions, atropine, antihistamines for mild reactions, and bronchodilators such as albuterol for respiratory symptoms. Emergency equipment includes immediate availability of a crash cart and oxygen. Another complication to discuss is contrast extravasation, which can cause serious problems. When contrast media leaks into surrounding tissue, patients will immediately experience symptoms including pain, swelling, and a burning sensation at the injection site. Contrast material acts as a chemical irritant, causing inflammation and discomfort. The high osmolality draws water in from the cells, leading to cellular damage. The concern of extravasation is that tissue damage can continue to develop over time. Peak reactions typically occur 24 to 48 hours after the incident. Severe complications can begin within 6 hours. Because of the progressive nature of the injury, patients' injection sites must be carefully evaluated before letting the patient leave the department. In severe cases, extravasation can lead to serious tissue damage. A patient may develop vesicular lesions similar to second-degree burns, skin ulceration and blistering, tissue necrosis, and most seriously, compartment syndrome, which can compromise blood flow to the affected limb. Immediate treatment of extravasation includes stopping the injection, elevating the affected extremity above heart level, documenting the incident, and marking the affected area along with notifying the supervising physician. Warm or cold compresses can be applied to the skin for 15 to 20 minutes and repeated every 4 to 6 hours for the first 24 hours. The patient should be monitored for 2 to 4 hours to observe complications. Warning signs requiring immediate attention include increased swelling or pain, skin blistering or ulceration, altered tissue perfusion, changes in sensation, and color changes to the affected limb. The department should contact the patient the next day and continue monitoring the patient until resolution of all symptoms. Most cases, or about 97% of extravasations, result in minimal or no long-term injury when properly treated. The key is early recognition and appropriate immediate management. There are several contraindications and considerations for IV contrast administration. These include severe renal dysfunction with glomerular filtration rate less than 30 mLs per minute per 1.73 meters squared, which represents the most significant contraindication. Certain medications require special attention, particularly metformin, beta blockers, and nephrotoxic drugs. And additional caution should be taken with diabetic patients, those with renal impairment, and elderly individuals. And finally, now we'll talk about how contrast media is used in nuclear medicine. IV contrast plays an important role in enhancing diagnostic capabilities of nuclear medicine hybrid imaging, mostly being used in PET-CT imaging. In PET-CT, IV contrast significantly improves lesion detection and characterization, particularly for lesions that don't accumulate FDG. It increases lesion conspicuity by highlighting perfusion characteristics that differentiate lesions from surrounding tissue. It is essential for reliable detection of liver neoplasms, renal lesions, pancreatic masses, and intramuscular disease. The primary indications include head and neck cancer staging, thoracic malignancies, abdominal and pelvic tumors, lymphoma staging, and melanoma metastasis evaluation. IV contrast administration in PET-CT follows specific protocols to optimize diagnostic accuracy while minimizing artifacts. Typically, 100 to 150 mLs is administered with contrast injection beginning 50 to 70 seconds before CT acquisition. Flow rates usually range between 2 to 3.5 mLs per second. Usually, the portal venous phase is imaged. However, the arterial phase may be added for specific indications like liver lesions, and delayed phase imaging can be performed 3 to 5 minutes post-injection for certain applications. Finally, oral contrast can be used in PET-CT imaging, serving a specific purpose and following established protocols for optimal diagnostic results. It is usually used to improve bowel distension and visualization and to differentiate between physiological and pathologic abdominal uptake. All right, so there you have the sixth Pharmacy 15. Let me summarize the key points we covered. First, contrast media is a vital diagnostic imaging tool that uses iodine atoms to enhance visibility of blood vessels, organs, and tissue during scan. The media can be classified by chemical structure and ionic properties with key characteristics including iodine concentration, osmolality, and viscosity. Contrast follows a two-compartment model in the body, reaching peak plasma concentration in 2 minutes and being eliminated primarily through the kidneys. Adverse reactions can be anaphylactoid, chemotoxic, or vasovagal, with modern non-ionic agents having significantly lower reaction rates than ionic ones. Key safety considerations include contrast-induced nephropathy, or CIN, drug interactions, especially with metformin, and the risk of extravasation. In nuclear medicine applications, particularly PET-CT imaging, contrast media is typically administered in 100 to 150 ml volumes, 50 to 70 seconds before CT acquisition to enhance diagnostic capabilities for various conditions, including cancer staging and tumor evaluation. So please review your notes and the summary document on Moodle and work on your flashcards focusing on these 4 key areas. Join me next time for our final Pharmacy 15 on theranostics and blood labeling medications. Feel free to reach out with any questions at any time.